everyone. I'm Chris Moriates from Dell Medical School, and during this brief presentation, I'm going to share some examples about how we can make health system science real for trainees. I don't have any relevant financial relationships to disclose. Some of you may recall the classic blockbuster movie, A Few Good Men. And in it, there's a scene, probably not the one you immediately think of, but it's in the courtroom, and a Marine is on the stand, and he's being asked to describe how he knew to perform code reds to punish his colleagues. And the defense attorney, a Marine, is asking him to point out where code reds are described in the Marine handbook or the standard operating protocols. And of course, they're not there because this was an informal mechanism that they used to punish Marines. So he says something along the lines of, "You mean that there's no manual or guidebook, standard operating protocol, nowhere written down that tells me that my duty as a Marine is to perform these code reds?" And the Marine on the stand says, no, sir, there's not. And the lawyer turns to smugly sit down. And then Tom Cruise stands up. And Tom Cruise asks the Marine, "Can you please point to where the mess hall is described in the standard operating protocol or in the manual?" And of course, it is not. So he asks, "Well, how did you know where to go to get food? How did you know where the mess hall was?" The Marine thinks about it for a minute. Says, "Well, sir, I guess I just followed the crowd at chow time." And I tell this story because I think it is such a poignant example of it's really important for us to write things down, to have protocols, to teach, to talk about best practices. But really, unless we are implementing this within our learning environments, our learners, our medical students, our residents get into the clinical learning environment and they immediately learn how things are really done. So while many schools, ours, many of yours, have started to implement health system science curricula and have created educational programs, either programs that are comprehensive, focused around health system science, or at least that incorporate these domains into other components of our educational curriculum. So talk about population health and clinical informatics, economics, healthcare structures and processes, value, improvement, safety, along with a renewed interest on leadership and interprofessional education, teamwork, systems thinking. I was recently at a AMA, Accelerating Change in Med Ed thematic meeting, which brought together many of the leading schools around these ideas of health system science. And we're hearing from these groups about all the different things, all the different educational initiatives, different classes that they've put in place to teach about health system science. But a real clear common gap emerged, which was that many were still struggling with how to get their students to see this health system science as something that was real, something that was part of their day-to-day lives or their future lives in clinical care. And so it became clear, I think, that we really need to help create the mechanisms and draw those connections for our learners so that they see that health system science truly is a third pillar, that it's not something in the classroom, but is something that is applied knowledge and skills and behaviors that are applied in our daily work as current and future physicians. And one way to do this is to really create and to support what my colleague Vinny Aurora and others have called bridging leaders. Those of us who participate in the educational enterprise, develop curricula around health system science, but then align those educational and clinical priorities, goals, and opportunities together, reaching across into the clinical environment, implementing systems changes that reinforce that alignment. We actually need people who are in both of those environments and who are working and supported to create those connections. So let me give some examples about how I think we've been able to help make health system science real during clinical training at Dell Med. First, I'm going to back up and look at a systematic review that came out a few years ago in JAMA, back actually in 2015. And it was looking at examples of training physicians to provide high-value, cost-conscious care. Now, of course, I realize that value is just one domain within health system science, but I think that this framework applies really well to the larger health system science umbrella. And so when they looked at these efforts and looked at studies that looked at effectiveness, they suggested there are 3 factors that aid in successful learning. The first is effective transmission of knowledge. So of course, you need to teach the content. You need to have ways that we teach about the basic foundational components of health system science. There's knowledge gaps, and many of us, like I said, have creative mechanisms to do that. In fact, I'll mention at Dell Med, as many of you hopefully know, we have a freely available tool, Discovering Value-Based Healthcare, which are interactive modules that many medical students, trainees, and faculty across the country have been using to share that foundational knowledge. We can apply best practices, of course, to create interactive opportunities. And we also need to facilitate reflective practice. I'll describe a little bit about what that looks like within health system science. Lastly, create a supportive environment in which the organization of the healthcare system, the presence of role models who deliver the type of care we want to see, and a culture of, here they say high value, cost conscious care, but we could say a culture of advancing health system science is reinforcing that desired training goal. So we'll also focus in on that. One way that we've created a sort of forcing function to make this a real component of our everyday clinical lives is we've adopted the SOAP VS model, which was developed by Dr. Eileen Moser and others up in Pennsylvania early on, years ago. But we've adapted it and adopted it. We've created these pocket cards that we share with our medical students before they go on their clinical rotations. And we've shared this model with the faculty and the clerkship directors across all of our clinical rotations. And what it is, we ask our students when they're doing a verbal presentation, a normal SOAP presentation, to add a value and safety component, to ask themselves and to share with their team. If you've proposed something, whether it's a new lab or test or procedure or medication, will this actually change management, and does it incorporate evidence? How does it incorporate the evidence as to a best practice? Have I considered the patient's goals when coming up with that plan? And to consider, what is the cost, actual relative, of the test or treatment? On our pocket cards, we give resources about where to go to get actual relative costs and how to think about that. We also have them think about safety. Is there an opportunity or a safety risk? Is the patient on DVT prophylaxis or not on DVT prophylaxis appropriately? Are there risks for medication errors, communication errors, transitions of care gaps? How can you, as the trainee, as the student, or as the resident, contribute to their care in a value-added way? Another example of this is we've taught our medical students how to perform health-related social needs screening for our patients on the internal medicine service in the hospital. And so we share with them and train them to use the Prepare assessment tool, which is a validated tool to identify and address a number of health-related social needs in our patients. And this became particularly important during the COVID surge. I guess one of the first of what are becoming many COVID surges. And during that first surge, our students were pulled off wards, and my colleagues had created this really innovative transitions of care elective, where these students were able to use these skills in health system science that they had developed and apply them even remotely. So they would be able to call our patients at the hospital and perform the screening tool with them, and then pass that forward to the team about potential issues that they had identified, connect with the social worker, or as we now have a community health worker who sees these patients, in order to plug patients in with resources that they may need to ensure appropriate follow-up with patients. So this is another value-added role where the students themselves are learning how to apply concepts of social determinants of health, of patient-centered care, of interprofessional teamwork, of value, quality, safety, and contribute to our teams in meaningful ways. And then we help contribute to reflections. One of the ways we do this is that really making those connections between what we're teaching around health system science and what they're seeing and doing explicit, making them visible and valid. So for our Dell Med students, they do their clinical rotations during their second year. And between each clinical rotation, we have an intersession day. So they finish their rotation on Friday, they have the weekend off, and then on Monday before they start their new rotation, we have an intersession with the entire class. And there's a number of components to that, but one of them is health system science training. And we start pretty much every session of health system science by giving the students an opportunity to share what they were really seeing on the wards or in the clinics or whatever. We've got them from all of their clinical rotations to share good and bad examples of health system science. So when teams worked well together, or when there was a lack of good interprofessional coordination and teamwork and what they saw. And by making those connections, by having them reflect on them, by having them share them, it becomes really clear, I think, to them and to us about how these concepts can be applied, not just taught about, not just written about or thought about, but applied. Another mechanism for creating those reflections is through our, we have these templates, that write-ups that many of our students are asked to do during their rotation. So during internal medicine, all of the students do a value and safety write-up. They do it during their surgical rotations and pediatrics, where they take a patient case that they had seen, an H&P that they've written, and they reflect on those questions around value and safety and increasingly equity. So we've implemented some equity reflection questions as well. And they write about the opportunities there. So taking real world examples and applying them. And oftentimes it's incredible the nuanced discussions that these students have through these reflections, through these write-ups about how to take the best care for the patient in front of them and how to treat the system around them and coordinate the system in order to provide that care. Now, obviously, as medical educators, we all know the importance of role modeling. And role modeling, of course, is particularly critical in advancing these goals of health system science, as was pointed out in that Stammen et al. Article. So we do a number of faculty development sessions to teach our faculty about how to teach and how to incorporate health system science concepts. We've described in this Shine Academy in the past our Patient Safety Teaching Champions program, where we have faculty who are nominated to participate as patient safety teaching champions, and we reflect on and advance our shared goals around how to teach patient safety. We also teach examples like this. So I've adapted this example from the health system science textbook. This is not a verbatim quote, but we'll use this adapted example. So 4 days after prior discharge for a new diagnosis of heart failure, a 71-year-old man is brought by ambulance to emergency room with shortness of breath. And in the ER, he is found to be tachypnic and hypoxic, and a chest x-ray suggests bilateral pulmonary edema. Classic, common scenario. Pretty much any medical student on an internal medicine rotation will likely come across a similar scenario. And as clinical educators, most of us immediately start to be triggered as to the areas where we can focus in and teach, right? So we can certainly start to talk about the mechanism of shortness of breath. We could tie it back to their preclinical curricula and get the students to be thinking about, why is this patient short of breath and what are we going to do about it? We could ask the students or the residents to interpret the chest x-ray and to look at this chest x-ray that was read as bilateral pulmonary edema. Show that to me. Tell me what you see. We can talk about diuretic dosing, mechanism of action, many favorite classic teaching topics for internists. But within this very same STEM, there are lots of hidden opportunities for us. So we teach our attendings, we can think about, hey, this is a great opportunity to also talk about care coordination, community resources, social determinants of health. All these examples, health system science topics that this case raises that we want to once again make visible, valid, make those connections for our learners. How do we reinforce that behavior? How do we encourage our faculty to do this in their day-to-day lives? Well, this I think was a brilliant addition by our own medical students. So part of the Choosing Wisely Stars program that I lead, which is a national program, some of your schools participate, all of you are welcome to, where we teach our students to create educational initiatives within their own schools. And our Dell Med Stars came up with this Choosing Wisely Stars Award, where they have their own classmates nominate and award clinical teachers, attendings, and residents who support high-value care, choosing wisely education during their clinical clerkships, whatever that looks like to the student themselves. So when students feel that they're being supported in this way, they nominate their teachers for this award. And then we publicly give this award at our big Dell Med Ed symposium. So in front of our dean and all of our chairs and the community, we highlight this as an example of what our students are wanting to celebrate. And we give these pins that they made for people to be able to put on their white coats. And that helps, I think, create that positive reinforcement, that culture of saying, this is what we want to see. It's an example of medical students leading from where they stand. An example we've seen over the past decade or two around quality and safety, where trainees may have had more training, more insights into quality and safety than many of their teachers may have. The students can manage up, can teach the team. And through SOAP VS, through our Choosing Wisely Award program, I think they do exactly that. But another way, and one that I really want to highlight here, is I think a way we've gotten traction is by truly putting these ideals within our assessment. So the AMA, of course, points out a number of tools that could be used to assess health system science domains. And I really want to get us to that top level of the pyramid, the showing what people actually do. Creating assessment tools, creating methods to elevate these behaviors. So these three phenomenal women who I work with in the Department of Medical Education have really led the development around our assessment strategy for our clinical clerkships. So Drs. Beth Nelson, Luann Wilkerson, and Stephanie Corliss, and have created these unique, I think, clinical clerkship assessment forms that are used across all of our clerkships. And I'm just focusing in obviously on a couple of the questions within this assessment. That is, all of our medical students are assessed by their faculty across these domains. So in treatment plan, you'll see here that in order to perform at the exceeds expectations level, these students are using value-based care, considering patient preferences and costs when suggesting and justifying next steps. And they're engaging the patient, family, and shared decision-making. We assess our students in systems-based practice, ensuring that they're practicing and role modeling interprofessional collaboration. We evaluate them on how they apply healthcare system context, as you can see, as well as the concepts of patient safety within their clinical rotations, and applying the skills and behaviors of leadership that we teach them. And here's the thing. So one, when you start putting this within their evaluations, you're clearly making it obvious to the students that this is important and that this is part of being a good physician. Implementing these behaviors, taking on health system science is just as critical to being a good physician as knowing which antibiotic to prescribe, as being competent within the clinical practice. So really important. And the other thing that I think is a bit hidden, but I think actually is maybe even more important, is we ask our faculty and our residents to fill out these evaluations. And so when you do, you're essentially teaching all of them what those behaviors are. So if they don't know what health system science practice really looks like, here's a description. And when they're doing it over and over again and realizing that this is what we expect of our medical students, you know that that's telling them that this is what we expect of you. And so we're creating that culture, we're raising the bar around what it is to apply health system science within the clinical learning environment. And this is important because we know that the environments in which medical trainees learn have lifelong effects on their medical practices. This has actually been shown in a number of settings that the way medical students, and particularly residents, more so residents, but there have been some studies looking at medical student practices. They're ingrained during their clinical experiences, and they last with them. So even if they move away into a new environment, and even if the culture or the practices are very different, they take with them the same sort of practices around quality and safety, around overuse or cost consciousness into those environments. And so we can make a huge difference early on by incorporating these principles, not just in the classroom, as many of us are doing, but reinforcing them in the environments where they practice. So I thank you. Happy to share any of these tools or examples. Please feel free to reach out. Wish that we were sitting in a room together, but instead I appreciate your attention for this virtual presentation, and I hope you enjoy the rest of your virtual conference. Thank you very much.